Pardon me? Yeah.
Hello.
Dr. Lakshmi Narayani, we hand over the proceedings to you. You can start the proceedings now. It's all the stage is for you.
Yes.
Dr. Lakshmi Narayani, have you logged in with 2 devices?
I'm logged in. Yes, I'm in 2 devices. I'm speaking from my cell phone, and my PG is telecasting in my department.
No, but yeah, sure, but they are not together. No, you are not close to that device.
No. I'm outside the college, outside the campus. He is in the department.
Okay, fine. So, on behalf of the academic committee of the Coimbatore Medical College Global Alumni, we have great pleasure in inviting Dr. Lakshmi Narayani, Professor of Surgery at Coimbatore Medical College Hospital, to conduct the session. Over to you, Dr. Lakshmi Narayani, to conduct the session. Thank you so much to you and all the faculty at CMCH, the Dean of Coimbatore Medical College, Vice Principal, and the speakers of the day. Thanks to Dr. Karupusamy and Dr. Einstein for accepting our invitation and for being with us. Now I request Dr. Lakshmi Narayani to conduct the proceedings. Thank you so much.
Good evening, ladies and gentlemen. It is a great honor to be here. I am Professor Dr. Lakshmi Narayani, HOD, Department of General Surgery, Coimbatore Medical College. And on behalf of Coimbatore Medical College and Global Alumni of CMC, we proudly invite you all an academic program on emergency medicine scheduled for evening through digital platform in view of COVID pandemic. First, I would like to welcome our prestigious Dean Madam, Professor Dr.A.Nirmala, Dean Coimbatore Medical College, who wholeheartedly extends her support and be the motivation behind us in conducting this program. I welcome Dean Madam. Welcome, Madam. Next, I would like to extend a special welcome to our special guest and speaker, Dr. Arunachalam, Einstein, Emergency Physician, Providence Regional Medical Center, Washington State, to spend his valuable time with us to enlighten us on TAEI concept in polytrauma. Welcome you, sir.
Thank you.
Going to be an excellent opportunity for the students, especially undergraduates as well as the postgraduates, to learn from you. I would like to welcome our professor, Dr. K. Sivakumar, Department of General Medicine, Coimbatore Medical College, Professor T. Geetha, Department of General Medicine, and Dr. Nambirajan, Professor of Cardiology, who always lend their valuable support and guidance in the management of 3 pillars of TAEI: stroke, poisoning, and myocardial infarction. Welcome, sir and madam. I would also like to welcome our Associate Professor, Dr. Karupusamy, Associate Professor of Emergency Medicine, who guide TAEI team and standing as a pillar in development of our emergency department. I would also like to extend warm welcome to all the participants of this webinar, our beloved colleagues, assistants, and students. I am sure this program is going to enlighten us in all the ways. Enjoy the show. Thank you all. I request our dean to facilitate the function. I request our Dean Madam to facilitate the program.
Dr. Lakshmi Narayani, I'm afraid that she has not joined us.
Just a moment, sir. I'm her PG speaking on her behalf. Ma'am is reaching. Yes, ma'am, you can speak.
Hello. If our madam has not joined, I will ask her to join. Because we told her we will bring up her. Hello. Hello.
Excuse me, sir. Is ma'am audible right now, sir?
I think we hear a hello. I don't know who it is.
Yes. Lakshmi Narayani ma'am is trying to convey that she is trying to make the dean join the meeting, sir.
Okay. If she's not available, would you think that we will go ahead with the session, and whenever she comes online, in between the two talks, we can request her to speak if she's busy?
Just a moment, sir.
Yeah.
Meanwhile, we can ask Geetha or Sivakumar to talk a few words about this program. Because Sivakumar knew about the program, no? So let me start.
I think Professor Lakshmi Narayani, I think, yeah, madam is joining now. Okay, fine. Yeah.
Hello.
Good evening, Dr.A.Nirmala. This is Dr. Bala Venkat. I think we look forward to hearing from you. Hello.
Excuse me, sir. I guess Lakshmi Narayani ma'am and Dean ma'am are on voice call right now, sir. Just give me a few minutes.
Okay.
Yeah.
Hello. Hello.
Yeah, welcome,
Yes.
welcome, Dr. Nirmala.
Yes. I'm little busy because of the so much rains, water clogged inside the campus of CMC. So I was little busy with the thing. I totally forgot. Sorry for the delay in addressing. Thank you. First of all, I apologize for the late. Good evening to all. First of all, I congratulate the team of the Coimbatore Medical College and the global alumni of the CMC for having arranged an important and most needed academic program on emergency medicine. Nowadays, what happens is death is due to non-communicable disease rather than due to the communicable disease. Non-communicable disease in the sense it is maybe due to the hypertension and the diabetes, or it may be due to the other events like trauma. So that is a need of our that everybody should know about the how to tackle a patient when they land into the emergency department. Also, the emergencies nowadays are not only previously we used to thought the surgical emergencies are the only emergencies, but it is not so. Even the medical emergencies are considered very important now. That too in our TAEI program, that is Tamil Nadu Accident and Emergency Initiative. Most of us know the program which is initiated in 2017 by the government of Tamil Nadu. They are taking MD, National Health Mission is taking so much steps to enhance the emergency medicine. I'm proud to tell that we are going to get 5 seats of emergency medicine in the 2022 and 23. That we are planning for it, and we are going to have it. That all the steps are taken for it. And also, what I mean to say is that TAEI is the one thing that will come that has 6 pillars. That is road traffic accidents. Then comes the poison. Then comes the burns. Then stroke, STEMI, and the PRAME. That is PRAME is that pediatric emergencies. All these are coming under the program of the TAEI. The TAEI program is the one that is going to save many lives of the patients. Even now, there are certain norms are given by the government that how the TAEI ward should be, how the triaging should be done. Everything is we are doing it. And now we are having, as CMC is concerned, we are having 2 medical officers. That is even I'm just briefing about the TAEI program college because most of the other people, global alumni, may not be knowing about the TAEI. We are having 2 medical officers, that is E1 and E2. That emergency medical officer, he will receive the patient and triage the patient and resuscitate. Meanwhile, the E2 will also join if the patient is critically ill, and E1 will triage, and he is responsible for doing the entries, everything. And E2 will take over the patient from E1, and he will proceed with the other investigations and other management. The simultaneously it should go everything as dictated by the ATLS protocol. ABCDE, that is primary survey and secondary survey, is done by our E2 and also by our postgraduates and residents, and they will manage the patients according to the severity. They will triage the patients in the green, yellow, and the red zones. This is how we are following in our hospital. And after stabilization and after the acute the patient, that is what we are practicing now. Most of the emergencies are taken within 6 hours. And also regarding the stroke and STEMI, the STEMI, if it is they are doing the pharmacoinvasive therapy, and also they are doing primary PPI in our institutions. I am happy to say that, and we are the one among the best with the minimum faculty. We are doing the maximum care procedures. And the other thing is regarding the stroke, our team neuromedicine, and if at all if there is a need for the surgical intervention, neurosurgery is playing a great role. And the neuromedicine people, as soon as the stroke patient comes, that too, if they reported to our department within 6 hours, they are using the Altipace and they thrombolize the patient. This is how we are doing the STEMI, stroke, everything. And also poison, they are managed very well. And snake bite, we are proud to say that the death rate in the CMC with the snake bite is very, very less. But we are reporting too many. I mean, I cannot produce the statistics now. Even otherwise, we are the one having the highest number of the snake bites from in and around the districts, nearby places. And this is how we are going on our TAEI program, and we are going to make everything useful. Even our people, emergency thrombectomy is done. Last week, they have done 2 cases, and we are on it. We are progressing every day. And I'm thinking it is a need of our, it is not only to the people, those who are working in the TAEI ward alone, that is in the emergency department alone, but also for each and everyone should know how to manage a patient if they landed up into the emergency. Not only it is the thing that is in the hospital, pre-arrival also, wherever we are, patient is in an emergency situations, we must be able to have the competency in managing the emergency. So I wish this is the topic which is a need of our. I wish you all success, and I think this is going to be very useful for our younger generation. Thank you for inviting me for such a wonderful program. Thank you. Wish you all the best. Thank you. Hello. Hello.
Yes.
Next. Sasi. Sasi.
Actually, Dr. Lakshmi Narayani is supposed. Hello.
Narayani, I've joined now.
Yeah, Madam. Dr. Lakshmi Narayani is supposed to conduct.
Bala. Bala.
Yeah.
Hello.
Yes, Dr.
Shall I
Nirmala.
leave?
Yes, Dr. Nirmala.
Yes,
Thank you so much.
since Director Sir is going to visit our hospital,
Yeah,
I'm
no
little
problem.
busy.
No. Thank you so much for being with us. Thanks,
I
Dr.
will
Nirmala.
join with you sometime later.
Oh, yeah,
I
sure.
will join with you sometime later.
Yeah, sure. Thank you so
Thank
much.
you. Thank you.
Uh,
Thank you. Thank you.
The presentation
Over to Dr. Lakshmi Narayani.
Yes, now I'm going to talk about the speaker, Dr. Einstein. So Dr. Arunachalam Einstein, he is a graduate, undergraduate, MBBS graduate of Coimbatore Medical College, and he did his residency in general surgery at Grand Medical College, Bombay, India.
One second. Yes,
And his residency in internal medicine at State University of New York at Stony Brook program, County Medical, and he is the chief resident in internal medicine and part-time emergency physician at St. John's Episcopal Hospital, South Shore. And he is the emergency medicine resident at Cook County Hospital, and he is board certified in emergency medicine and board certified in internal medicine. And he is at present working as an emergency physician at Providence Regional Medical Center. And he is licensed to practice medicine in the state of Washington. Next. And his academic accomplishments, he got 98% in training exam for year 1996, 99% in training exam for year 1997, 98% in training exam for the year 2004, 99% in training exam for the year 2005. And his honors and awards is the best house officer of the month at Nassau County Medical Center, October 1994, and he received the Primary Care Resident of the Year award at Nassau County Medical Center in June 1997. He is the chief of the medical staff at Midsel County Hospital, and he has given some research papers. So, at improving syndrome surveillance case definitions and outcomes by using existing data and applying cost benefit theory to public health syndrome surveillance programs. And he has written some chapters in the book. So, encephalitis and the syndrome of inappropriate antidiuretic hormone secretion. He has given lectures and presentations, acute abdomen in pediatric patient, childhood period pancreatitis in October 2003, and acute coronary syndrome in October 2004, and venomous snake bite in 2005, and sepsis in 2006. And he has conducted many webinars during COVID pandemic to educate other physicians and general public, conducted many continuing medical education programs. He is the membership in professional societies as Fellow of American College of Emergency Physicians, Fellow of American Academy of Emergency Physicians. And he has won the first place in 1,500 meters and 5,000 meter running race in Coimbatore Medical College. Next, I ask the next speaker to tell about the second speaker, Dr. Karupusamy.
Whether Sivakumar is there or not.
Okay. Sir, Dr. Sivakumar, Professor of General Medicine, Coimbatore Medical College, I request you to tell about the speaker, Dr. Karupusamy.
Madam, if he's not able to do, can you do it yourself?
You people are not allowing him to mute, it seems. I have received a phone call telling that.
Because we are not aware that he's a co-host.
Okay.
We'll make him a co-host. Savita, can you make...
So Dr. Sivakumar is already a co-host, sir.
Okay. So that means he will be able to unmute himself.
Yes, yes, sir.
But he's finding difficult to unmute, sir. That is the phone call I received just now.
Madam, ask him to try it again.
Okay, sir.
Yeah. Savita, can you unmute everybody? Let him start speaking, then we will mute.
Okay, okay, sir. So now everyone can unmute themselves. You also have to again unmute, sir.
Yeah. Can we now request Professor Sivakumar to speak?
Yes, sir. I will ask him to speak, sir.
Yeah.
So Dr. Sivakumar ID is correct, na? Dr. Sivakumar K, I have made the co-host. One more Shiva Logesh is there.
No, Sivakumar is the professor of medicine.
He's unmute now. He's unmute.
Madam, I am Dr. Sivakumar, Associate Professor. Hello.
Yes, sir.
I am here for the vote of thanks. There is another professor.
Yes, that's another Sivakumar. Okay.
Okay.
Dr. Lakshmi Narayani, can we go ahead with the first talk?
1 minute. Sorry. Okay, but Sivakumar sir unmute. Adade unga. Okay, yes. Okay. Now Karupusamy has to talk. Now I ask Dr. Karupusamy, Associate Professor of Emergency Medicine Department, to take over the program to TAEI. Dr. Karupusamy, sir.
Good evening, madam and sir.
Yes. Yes.
Respected Dean, madam, and Professor of Surgery and Professor of Medicine, and other professors also, and our alumni members also, and our colleague also, and our final year and house student also, and postgraduate student in the medicine surgery department also. And now only sharing topic now.
Thanks. Great. One body iron.
I am Dr. N. Karupusamy, Associate Professor of Coimbatore Medical College Hospital in Emergency Medicine. I talk about the TAEI concept in Emergency Medicine Department. This is for TAEI logo. Tamil Nadu Accident Emergency Care Institute is otherwise called is TAEI. Our motto is saving life in our mission. So why TAEI? What are the aim of the TAEI project is to streamline the workflow mechanism in the emergency room. Our beloved Dean Madam also talk about the EMO 1 and EMO 2. EMO take over the green zone and air entry, and EMO 2 take over the red zone and HSTU and yellow zone also. The coordinate movement of the EMO 1, EMO 2 you take over the emergency department room also. So streamline the workflow mechanism in the emergency department. Integration of the multiple discipline of the healthcare. So Madam already told us STEMI and stroke and trauma and burns, even poison and snake bite and pediatric emergency also you take over the integration of the all the healthcare. Third is you develop the protocol driven models also. You got 2 protocols available, STEMI protocol also available, and the stroke protocol also, script protocol also available. This will be a nurse centric, maybe it's a coordination of the all the staff nurse and medical officers. So not only preference to the medical officers, both is a staff nurse and medical officer in the emergency department. Patient give the optimal care with the minimum time delay. So let us discuss about the each time we can use it for the triage and primary survey and second survey part. So we minimize the time delay. Finally, establish the emergency department with the all essential component. Madam already told 2017 onwards, you got to establish the TAEI concept in our emergency department. But emergency department developed only last 6 months only. Future also we get the 5 medical seat also. So this is a 6th pillar of our TAEI. First is the stroke and second is the STEMI, ST elevation MI, next is the trauma and another is the burns and another is the poison. Prime means otherwise a pediatric emergency. In the TAEI emergency department, we continuing first is a triage and decontamination area also. Second is a green zone and observation bay also available, and the visitor also available. And emergency investigation bay also available in red zone, yellow zone also. We got a HSTU, hybrid dependency units equal to the trauma ICU. We got a emergency OT also available. The point cover lab also available. You can do all the CBC, RFT, LFT also. You got ultrasound also. If fast, you can assess the any hemoperitoneum and splenic injury, liver injury also. Then the mobile X-ray also available in emergency department. Nearby, you got a MRI, CT scan, even X-ray available also. Along with you got a facility of cath lab and biplane cath lab also available. So what are the objectives of the TAEI to attain the sustained development goals? 2020, you have the number of the death injuries from the road traffic accidents we can reduce. But our Tamil Nadu goal was we can achieve the half the number of the 8,500 in 2023. You can standardize the management of all the medical surgical emergency into the free-defined and distinguished stage to have specific clear protocol for the management of the each stage. So you get a protocol of the trauma, protocol of the MA, protocol of the stroke also. To triage the patient into red and yellow, green category and institute the appropriate management. To ensure the definite treatment for the injury within the golden hour, to have time norms for procedure in the emergency department. Our National Health Mission also developed the trauma rescue software also in emergency department. So you can treat the injury patient within golden hour also. We discussed later also. To start the process of the rehabilitation early as possible. Not only you can primary survey, secondary, you can early you can start out the rehabilitation early as possible also. So in TAEI concept, main is time and time also. You know the time is a muscle in case of ST elevation MI also. Time is most important in case of stroke. You got a thrombolysis, you can preserve the neuron also. So time is healing, early intervention, early healing, you can send the back to the home also. So time is most important for the outcome also. Time is most important for the money also. You save the money also. So most of the time norms. You can understand every bank, you go to the bank, you got a time norms for the, you can put the DD and put the sum of the check also. The same norms you can apply in the TAEI concept. So our time emergency department time norms, you can start with the 2 minutes to 360 minutes. So within 6 hours, you can manage the patient from the from previous center or straight away from our emergency department. You can manage it within 6 hours. So first stage, you can triage. If the patient come to the ambulance, you can receive by triage area. This is already told. This is a nurse centric. The triage area is seen only by our staff nurse. Triage nurse is staff nurse. According to the patient condition, you can segregate the patient into the red zone, yellow zone, and green zone. This triage is taken into 2 minutes only. After patient shifted to the green zone, red zone, yellow zone, another is you can primary survey is 2 minutes. So investigation along with the primary survey, along with investigation, another 4 minutes. So totally 8 minutes, you can manage the patient very well. Next is investigation. You could do the ultrasound, e-fast, mobile X-ray, and even CT scan also. Even thrombolyze the elevation patient even within 15 minutes in the red zone also. So guarantee made in the only in 30 minutes. So don't go through the first second entry in the area entry in early time also. So first establish the stage patient and stabilize the patient, and then later you can go in for medical legal formality also. Then followed by the detailed examination only. After 30 minutes, you can finish with the 45 minutes also. Then you got all the specialist opinion according to the patient. Not get all the specialist opinion. You get a neurosurgeon, neurologist, and general surgeon and plastic surgeon, orthopedic surgeon. According to the patient, you collect the opinion from the within 120 minutes, approximately 2 hours. Followed by you can monitor, evaluate the patient another 180 minutes. So within 360 minutes, you shift the patient from the emergency department to the respiratory department. You go to the IMC or medicine IMC or surgical ICU or neuromedicine or neurosurgery ward. So this is important for the time norms in the TAEI concept in the emergency department. So first is 2 minutes. Patient come to the ambulance. Tour to triage is 2 minutes, and tour to primary survey is 4 minutes, and tour to investigation of the for yellow and yellow area is 8 minutes. So 2 minutes in the triage area, the trauma rescue staff nurse is available in triage area. The starting of the patient into the red zone and yellow zone, green zone, according to the criteria, we later also discuss about. So red yellow zone patient straight away not go to the red yellow area. This maybe go to the restriction pay. You can stabilize the patient. You put the IV line. You can restriction the patient. Put the endotracheal tube, and after stabilization patient only you can go to the red zone, yellow zone. Green zone patient taken to the green area. This patient is comfortable. You can no signs of intracranial tension, any other complication not there. You can patient treated as a OP. You can send back to home in green zone patient. So how to criteria the red criteria and yellow criteria and green criteria according to the physiological criteria. So you see the in chart, you got a red criteria, airway, you got a noisy breathing may be there. And you look for respiratory rate less than 10 and more than 24 per minute, so tachypnea. Radial pulse may be present and absent also. You can pulse maybe bradycardia and tachycardia may be there. Systolic pressure also is less than 90, patient going for hypertension. Capillary refilling also more than 2 seconds also. We got a simple scale available is A, V, B, U scale is available. A for alert, V for verbal response, and pain response P. U for unrespond to the any response also. The simple scale, this patient only pain on AVB scale. The glossomascomal also less than 13. In spine injury, single birth count also more than 15. So this type of the patient, you can triage into the, go to the red zone area. What was happening in green criteria look like a normal, patient RV normal, respirator normal, SpO2 also more than 90%, pulse also normal, and systolic blood pressure also more than 90, so no hypertension. Capillary refilling also less than 2 seconds. Patient also alert in our simple AVB scale also. Glossomascomal also normal. In between, you got some patient may be there, patient RV normal, but respiratory normal, and SpO2 also more than 90%. Pulse is 50 to 100, and systolic pressure normal, and capillary refilling also less than second. But sometimes problem may be there with maybe chest pain, maybe, but ECG normal. We think of unstable, you can put it into the yellow criteria also. So ABB classification, patient only respond to the verbal also. Glossomascomal not less than 13, you can 13 or 14 or 15 also. So these are the criteria. If a patient arrive in the triage area, you can shift it to the red zone criteria and yellow zone criteria and the green zone criteria. So you get 2 minutes, another 2 minutes, you can finish the triage, 2 minutes for primary survey. Within the 2 minutes, you can restriction start along with the primary survey also. So primary survey restriction done simultaneously for the red zone, yellow zone patient. So already know everybody is A, B, C, D means, but the most important thing is control of the bleeding is more important than the A, B, C, D. So you can control the bleeding is first preference. Here for airway maintenance with the cervical spine embolization, mostly in our trauma patient, don't forget about the cervical spine embolization. Later patient going for quadriplegia and paraplegia also. So you can see the airway maintenance, you can stabilize the cervical pain. Next is breathing stabilization. And third is circulation stabilization of the hemodynamic. D for disability, you can see the any neurological status or any focal neurological deficit. E for exposure and environment also. You can anytime mask activity also coming. So exposed to the all the area. Look for you can poison also yellow codon poison. You can around the dressing also maybe there. The dressing in the yellow codon poison you can observe in the skin also. So look for the exposed area. Sometimes you miss the occult injury in back also. So E for exposure and environment. So simple two question on instruction by TAEI analysis, you can segregate into the red zone, yellow zone, green area. So TAEI nurse asks the what is your name, what was happened. So you tell the all the answer. So airway is pattern. So you get a sufficient airway research also perimeter speech. Ask the patient to elevate the both leg and move the both arms. So patient does not have the no neurological deficit also. So sensory must be clear. So TAEI is just asking two question or instruction. The patient you can segregate it. Another also things patient cardiac output normal. You can feel the bilateral radial and bilateral dorsal spadial pulsation present. So we think about the cardiac outputs also normal. So within 8 minutes, you can complete the registration of the red zone, yellow zone patient. So first 2 minutes triage and 6 minutes also registration. So airway, you can any secretion maybe there, you can put it to the section of the secretion. And if sometimes when patient sick, put on the endotracheal tube, even patient not able to put the endotracheal, you can go in for tracheostomy also. So breathing, you can easily put on the ABB bag. After endotracheal tube, you can connect it with the ventilator also. So you can circulation, you connect with the IV line and the central line. Maybe you can give blood also. Along with you got central line and IV line, you can draw the blood for the investigation also. So disability, you can put the cervical collar, heart cervical collar and spine cord. So you can prevent the injury to the cervical and the spine injury also. So also remove the source of poison and you can maintain the sometimes patient develops hypothermia. So you can maintain the normal temperature along with the warm blanket. So next 15 minutes, you can do the EFAS. It's available in our emergency department. You look for the any even ultrasound. You can find out the hemothorax and pneumothorax also. You can find out the hemoperitoneum. You can find out the splenic injury and liver injury also. Important things, you can assess the IV size also. You can it able to IV size. You can able to give the fluid. This patient got a volume overload or you got any fluid deprivation maybe there. You can find out the IV size. So mobile X-ray also available in our HSC department also. You take in the patient without mobilization patient. So you can dispatch all the sample into our point of care maybe there in first floor. You got the 24 hours lab available. So you can send the lab. So you can complete the catheterization. Even a patient got a chest injury and hemothorax, pneumothorax, you can put the intercostal drainage also. So within 15 minutes, you can start the thrombolysis. Okay, you got our duty EMO2 also there. Duty general medicine also there. You can MA can come to our red zone area. You can start the thrombolysis even within 15 minutes also. So patient near to our emergency department, you get a CT scan and MRI scan also. You can shift to the CT scan also. So now we'll come to the complete of the AR&D. Another 30 minutes. AR&D must be follow the restriction only. Straight away, not patient come to our triage area. Don't put the AR&D. And next 30 minutes, you can produce the close reduction to be completed. Sometimes you can complete the CT scan. Sometimes you can necessary for the MRI care for the cervical injury and spine injury also. So already Madam told less than 6 hours, we taken the emergency surgery into the emergency operation theater near to our emergency medicine department also. Even possible, you can do the emergency decompression within 45 minutes also. Sometimes patient also, madam also told in the STEMI patient, pharmacoinvasive therapy, patient also shifted on the cath lab. We got a 24 hours duty cardiologist available on CMC also. So every 24, even 24 hours, we do all the angiogram also. This time only you can complete the secondary survey, get through the from head to toe. You can, or any other injury, any involvement may be there, and complete the secondary survey from top to bottom. Next 16 minutes, you complete the treatment of, so you can maximum waiting in the green zone is maximum 60 minutes. So patient, you got no major injury, you got maybe taken the ECG normal. So look like a acute gastritis. This patient may be treated as OP, you send back to the home also. Sometimes complete the spine MRI if indicated. So 120 minutes, less than 2 hours, you got all the specialist opinions. So you got the neuromedicine opinion in case of stroke and the cardiology opinion, you get the MI. Sometimes you got necessary for the plastic surgery in case of the opinion the trauma patient also. So within 2 hours, you got all the opinion. Sometimes even our postgraduate of orthopedics and neurologist and neuromedicine and neurosurgeon and plastic surgeon, 24 hours available in emergency department. So easily you get all the specialty opinion within 120 minutes. So 180 minutes, you can spinal fixation in case of the instability. So within 6 hours, shift the patient from emergency room to respiratory department. If any MI patient, you can shift it to the cardiac ICU and cardiac ward. And stroke patient, maybe go to the neuromedicine department also. Sometimes you can shift it to the IMC also. So already madam told you got a 2 program, maybe there is a STEMI program and SCREET program. Our Professor Nambirajan also talk about the STEMI. So I get through the small things in our TAEI ward also. STEMI patient thrombolysis in emergency department itself. So we got EMO 1 and EMO 2 duty physician and a general medicine postgraduate and a duty cardiologist also available and a cardiology postgraduate also available. So you can thrombolyze the STEMI patient. Even you got a cardiogenic shock, even arrhythmia, you can stabilize the patient along with our teamwork. Patient thrombolyzed, stabilized, sent to the cardiology ICU. So you got a 24 hours duty cardiologist available. So you can run the angiogram in night time also. So this is a patient, you can save the life also. So any STEMI patient from peripheral hospital like Polaji GH, Metropolium, Uti, even Erode, Tirupur also, our duty cardiologist done the angiogram within 24 hours. So another program is stroke care. Stroke care in rapid intervention, plasmagen activator. So stroke patient come to the emergency department, thrombolyzed, even free of cost. Even injection altiplase costs about 25,000 to 35,000. Our NHM also you can contribute the 20 vials per year. So free of cost, you can do the stroke patient also. We got a good teamwork also, EMO 1 and EMO 2 and a duty physician and our medicine postgraduate. Duty neurology also available on call and neurology postgraduate every time you call to the duty neurology postgraduate, you can done the teamwork also. Our neurologist and neurosurgeon also done the mechanical thrombectomy in our biplane cath lab also. Our team of neurologists and neurosurgeon along with our radiologists, along with our CMC alumni members also contribute to the mechanical thrombectomy 2 cases also. Our Dr. Rajesh and Kartik Ram and Dr. Geetha and contribute the mechanical thrombectomy in the CMC also. So one of the golden hour of the trauma patient, you can NHM can put the trauma registry software. You can follow the patient each time you get any time lag between the treatment and the time lag in investigation. So one of the software you can upload in our emergency department also. The emergency department we had the computer in triage area and green zone, yellow zone, red zone, and HST also. High dependency unit like a look like a trauma ICU. So any patient received by 108, the ambulance EMT technician, emergency medicine technician enters the patient detail in the trauma rescue software in the smartphone held by an emergency technician. The patient detail come to the trauma registry software in triage computer. The triage staff nurse saw all the detail even before patient come to our hospitals. So what about the patient condition? What about the BP? What about the oxygen saturation? What was happened at the time? The trauma or any head injury may be there or not. If the patient receiving the triage area, the staff nurse enter all the detail in the trauma software. The software itself split the patient into the green zone and red zone, yellow zone according to the patient condition. So you easily can send to the patient to the particular zone also. EMO, EMO2 also enter all the patient detail into the computer software in green zone and the red zone. You can preserve the golden hours of the trauma patient, you save the life also. In futures, now you can come to the EMO2 level only. In futures, you can go to the specialist also enter the patient details. We can send the investigation through the software. You saw the result in the trauma software also. In future, we will digitalize all the case in emergency department. Okay, thank you. Thank you for patience.
Now I request Dr. K. Sivakumar sir to add upon some points as a moderator. So since there is no response from the Dr. Sivakumar, we'll proceed with the next topic. I request Dr. Arunachalam Einstein to start on the polytrauma. Sir, you are not audible. Yes.
Good evening, everyone. Thank you, Professor Lakshmi Narayani, for your kind introduction. I thank the Dean Madam, Dr. Nirmala, and everyone for giving me an opportunity to talk. And so I am just going to present a case which I saw 30 years ago when I was doing general surgery at Grand Medical College, Bombay. So I want to share my screen.
Sir, you have the permissions to.
Yeah, thank you. So everybody able to see the screen?
Not yet, sir. Not yet. Only we can see you. Not
okay, sorry.
Can the host allow Dr. Arunachalam sir to share his screen?
It says one
It's
participant
already
can
been
share at a
allowed.
time.
So
No, it says only one participant can share at a time.
can you try again, sir? Just once again.
Okay. Are you able to see the screen now?
Not yet, sir.
Are you able to
Yes, sir.
see?
Now we can see.
Okay, thank you. So this was a patient which I saw 30 years ago in 1991, August of 1991, when I was a general surgery resident at Grand Medical College, Bombay. And
Sir,
this
sorry
was,
to interrupt. Can you put it in a slideshow mode, sir?
yeah.
Thank you, sir.
Yeah. So this was a 37-year-old man was crossing the road and was hit by a minivan at low speed. And the patient was complaining of headaches, left-sided chest pain, and pain in both legs. And he was examined by the casualty medical officer and was found to have contusion in the head, contusion in the left side of the chest, and contusion in both legs. So he called, I was the first year postgraduate, surgery postgraduate, first month. And so we were just outside the casualty. And so he called us, me and the senior resident went and evaluated the patient. He said there is a trauma patient. His GCS is 15, and he's having some head injury and chest injury and injury to the legs. So, and these are his vital signs. His temperature normal, pulse was 124, blood pressure was 94/58, and respiratory rate was 24. So how do we approach a trauma patient? Advanced trauma life support by American College of Surgeons provides a structured approach to the trauma patient with standard algorithms of care. It emphasizes the golden hour concept, that is, timely prioritized interventions are necessary to prevent death and disability. As you know, in trauma, there is like trimodal phase of death. Like whenever there is a trauma, some people are dead at the scene. And those type of deaths can be prevented only by, wearing seat belts, having good roads, and wearing helmets. Nothing can be done. Physicians can't do much there. So then the second phase of death is within like few minutes to hours, and that death is the one which can be prevented by this protocol. So it starts with the primary survey, and Professor Karupusamy has already told about the primary survey. So consists of rapid systematic evaluation of the airway, breathing, circulation, and disability and exposure, and treating life-threatening condition as they are discovered. So if the patient is not having a airway, then you have to manage it immediately, then go to this breathing and then circulation, like that. Obviously, if somebody is like bleeding externally, you put a pressure. And a lot of times everything goes on simultaneously, like when there is a polytrauma case comes, like somebody is doing airway, somebody is assessing the chest and all this. And primary survey and resuscitation of vital functions are done simultaneously using a team approach. So the primary survey is like airway. A stands for airway maintenance and C is sign protection. So if the patient is able to talk, then his airway is open, and probably is having good cerebral perfusion. He's alert oriented. So I just go and introduce myself. I'm Dr. Einstein, and I ask their name and ask what happened. And if they are able to explain what is happening, that means their airway is open and they are having good cerebral perfusion. So next, breathing with life-threatening chest injury management. And C stands for circulation with hemorrhage control. And D, a brief neurological exam to look for head injury and spinal injuries. And E is exposure, expose the patient and have a look at front and back of the patient and cover the body with warm blankets, because hypothermia decreases survival in trauma. So airway maintenance with C-spine control precautions. Ensure a patent airway is the first priority in primary survey. That is the first thing. And a rapid assessment for signs of airway obstruction should be done. Like if there is any foreign body, any facial or mandibular fractures, tracheal or laryngeal fractures, and all those things can result in airway obstruction. So management, should be immediately recognized and promptly corrected. Any snoring, gurgling, stridor, hoarseness, and all these things are indicative of airway obstruction. And if the patient is unable to maintain a spontaneous respiration, or if the airway is not patent, then a definitive airway is indicated, which is endotracheal intubation. Even if the patient has a severe head injury and they are not maintaining their airway, if their Glasgow Coma scale is less than 8 and things like that, then we might have to take care of the airway. So C-spine protection is very, always assume C-spine injury in any patient with multi-system trauma, especially with the altered level of consciousness or a blunt injury above the level of clavicle. While assessing and managing patients' airway, great care should be taken to prevent excessive movement of the cervical spine. Immobilization devices used to protect the patient's spinal cord should be left in place until a cervical spine injury is excluded. So breathing with the life-threatening chest injury management, like if the respiratory rate is increased, you have to think about chest trauma, and also look at the chest movement, auscultate the lungs bilaterally, and look for the oxygen saturation. And you have to expose the chest and assess the chest wall, whether it is moving symmetrically, and palpate whether there is any subcutaneous emphysema, which can indicate rib fractures. And also look at the trachea, whether it is at midline. And so injuries that may acutely impair ventilation are tension pneumothorax, flared chest, pulmonary contusion, massive hemothorax, and open pneumothorax. Tension pneumothorax and open pneumothorax are identified and controlled in primary survey. So you have to control this before you go to the next. So most trauma patients need supplemental or put on supplemental oxygen. If you suspect tension pneumothorax, neural compression should be accomplished immediately, followed by chest tube insertion. And then tension pneumothorax is a clinical diagnosis. Do not wait for an X-ray result. So circulation with hemorrhage control, assess for organ perfusion. Patient is bleeding, the blood pressure, initial blood pressure may be normal, but see for like cool and clammy skin, sweating, and steady pulse. So shock in trauma may be hemorrhagic or non-hemorrhagic. It can be neurogenic shock, and tension pneumothorax can cause shock, cardiac tamponade, myocardial contusion. All these things can cause shock. But hemorrhagic shock is the most common and is the predominant cause of trauma death. And start 2 large bore IV lines. Start emergency blood transfusion if you have hemorrhagic shock. How do you control bleeding? External bleeding, direct pressure. Like a lot of people with head injury, scalp will be bleeding a lot. So you need to make sure that the bleeding is controlled. Otherwise, the patient might lose a lot of blood. Internal hemorrhage may require operative treatment. Internal source of hemorrhage may be in the chest, in the abdomen, in the pelvis, retroperitoneum, or in the long boards, femur fracture can people can lose up to 1,000 ml to 1,500 ml of blood, even if there is no external bleeding. And the one thing is, head injury doesn't cause hemorrhagic shock. There is not much blood we are going to bleed inside the head. Scalp injury can cause, but so disability, brief neurological exam for any intracranial hemorrhage. So assess the level of consciousness, check pupillary reflex, sensory and motor examination, and the exposure. The patient should be exposed fully, undressed fully, and complete. You have to visualize everywhere. Like when I was doing trauma rotation at Cook County Hospital, we used to see a lot of bullet wounds in other places. So you have to log roll the patient, so one person has to stabilize the C-spine, and the patient should not be moving. So the patient has to be log rolled, and you can see whether the patient has any tenderness in the thoracic lumbar spine or any other injuries and all those things. And once you have finished this, then cover the patient with warm blanket to prevent hypothermia. So secondary survey, it does not begin until the primary survey is completed. All resistive efforts are well established, and the patient is demonstrating normal vital signs. So head to toe evaluation. Here, secondary survey, you try to find out head to toe, whatever, any fracture is there and all those. Complete history and physical examination for each region of the body. You palpate the head, see whether there is any skull fracture, palpate the mandible, palpate the face, palpate the chest, palpate the abdomen. You do a complete history and physical examination of all the region of the body. Complete neurological exam is performed, including GC score. And the key in trauma is like you need to keep on reassessing the patient, doing primary survey again, because initially the patient might be fine, but suddenly the patient can deteriorate. So what I'm going to, we do EFAST at the end of the primary survey. Is a part of secondary survey. FAST is focused assessment of sonogram in trauma. So FAST, what we try to do is we try to find whether there is any bleeding. Okay. Mainly what we try to do is in the right upper quadrant, left upper quadrant, pelvis. We will see whether there is any blood accumulating in this area, and then also around the heart in the pericardium. So EFAST is the extended FAST, which we also try to detect pneumothorax. So how we do this is so there are 3 probes. This is curvilinear probe, and this we use for the abdomen, and this we can use for the abdomen, and mainly we use for the heart to check for the hemoglobin. This is a linear probe which we use for diagnosing pneumothorax. So right upper quadrant, you look at 3 inferior pole of the kidney and caudal tip of the liver, Morrison's pouch, and suprahepatic region. So what you do is you take the curvilinear probe, the mid-axillary line, you just here, this is the kidney and this is the liver. So blood accumulates between the kidney and the liver. So that's where you look for any hypoechoic area around that area. So this is the liver and this is the kidney. So this is the Morrison's pouch. So this is the most dependent portion, and you can see the kidney. And then the suprahepatic region. This is the liver. This is the white line is the diaphragm. So the fluid accumulates between the diaphragm and the liver. And also this is the thorax. So now between the liver and the kidney there is no fluid, and now this is positive FAST. the fluid is there between the kidney. This is the hypoechoic area. So this patient, if the patient is hypotensive, then has to be taken to the operating room. And now what we are trying to do is, next is we are trying to do find the fluid in the pelvis. So in the pelvis, what you do is you take the curvilinear probe and you keep it in the just above the pubic symphysis in the sagittal plane, and then what you try to do is the marker should face the head of the patient. And so what we try to do is, this is the urinary bladder, and this is the male patient. So, and these are the seminal vesicles and prostate. So there might be some fluid here. So you also have always try to find out the fluid here in the just below the peritoneum. So here we have the free fluid. So the FAST is positive. So this is the bladder, and here is normal, and this is hypoechoic area. So this is a positive FAST. Now in a female patient, this is the uterus, this is the pouch of Douglas fluid. You see the hypoechoic area in the pouch of Douglas. And now you go to the left upper quadrant, and if there's splenic rupture, so you have to see the suprasplenic area, then around between the spleen and the kidney, and in the left paracolic gutter. This is how you do it. Same way, just in the left, just below the left mid-axillary line, you go there. And now this is the spleen, this is the kidney. So fluid can accumulate between the spleen and the kidney. So you see for any hypoechoic area between the kidney and the spleen. This is the spleen, and this is the diaphragm. And the diaphragm is the white line is the diaphragm, but in the right side, fluid mainly accumulates between the kidney and the liver, but in the left side, it mostly accumulates between the spleen and the diaphragm. That is where most commonly you see the fluid. So you see the fluid here, it is normal. So and this is the kidney, and this is the spleen. So the next area is between the kidney and the spleen. And now then you go to the left paracolic gutter around the kidney, you see whether there is any fluid. So now this has fluid around the spleen. This is normal. Here you see here, this is kidney, this is spleen, and this is the diaphragm, and there is no fluid between the spleen and the diaphragm. Here you see this is the spleen, there is the hypoechoic area, which is positive FAST. So there is blood in the peritoneum, probably injured spleen. So if the patient is hypotensive, hemorrhagic shock, patient might have to be taken to the operating room. So now we are going to see the fluid around the pericardium. So what you do is you keep the probe just below the xiphoid process, and this is a apical 4-chamber view, and this is the heart, and there is no fluid around the heart here. So this is a normal heart. And this is normal. So now you see this is a fluid around the heart. This is the heart muscle, this is fluid hypoechoic area. So now what we can do is, now we are trying to find the pneumothorax. Here you take a linear probe, and then you use that, and you see the ribs. This is one rib, and this is another rib, and this is the pleura. So what we want to do is whether there is sliding between the visceral and parietal pleura. If there is sliding, then there is no pneumothorax. If there is no sliding, that means there is a pneumothorax. So this is the one rib and another rib, and this is the pleura. And here you see there is lung sliding here with respiration, but here there is no lung sliding. So this can be, patient can have pneumothorax in this side. So if there is a normal lung sliding, it rules out pneumothorax. And this is more sensitive than X-ray. And so here, the most confirmatory test is you have to find the lung point. Lung point is the place where there is transition between the normal lung and the pneumothorax. So what you do is, see here, there is lung sliding and there is no lung sliding here. So that is the transition point. If you see that transition point, then that's it. There's pneumothorax. So back to our patient. So when I went and examined the patient was confused. He was, and there were corruptus in the left side of the chest, and there was diminished breath sounds on the left side of the chest. And so, my senior resident, he was saying, he was talking to the patient, and he said that his breath smells of alcohol, and probably this guy has, is an alcoholic and he has drunk. So, but we were talking like that, he suddenly deteriorated and he suddenly became unconscious, and I could not feel any pulse. And meanwhile, the casualty medical officer had already ordered the chest X-ray. Chest X-ray had been done, so but we didn't see the X-ray, and this was the X-ray. I mean, this is not. I'm just getting a picture of the tension pneumothorax. So in tension pneumothorax, the trachea is deviated to the right, the whole mediastinum and the heart is shifted to the right, and the diaphragm is pushed down. This is and what it does is that with each respiration, there is a valve with each respiration. So as the intrathoracic pressure increases, the blood supply to the patient goes into shock and hypoxia and death if it is not treated immediately. So what happened was he put a chest tube. It took like about 6-7 minutes to put the chest tube, and the patient was in cardiopulmonary arrest, and we did chest compression for about 20 minutes, and the patient could not be revived, and he was pronounced dead. So postmortem examination, there was no intracranial bleeding, no intra-abdominal injuries. There were not contusion, but no fracture. Cause of death was tension pneumothorax. So learning points: need high index of suspicion for, what I learned from this case was, we need a high index of suspicion for tension pneumothorax, especially whenever somebody is having subcutaneous emphysema and the patient is complaining of chest pain and they are in respiratory distress, decreased breath sounds, you need to act immediately. Otherwise, the patient can die in few seconds, actually. Needle decompression might have saved this patient's life, because chest tube takes some time, the equipment comes and all these things. And altered level of consciousness in a trauma patient, we have to consider like hypoxia or decreased perfusion to the brain, or direct cerebral injury. So need high index of suspicion for tension pneumothorax. Needle decompression might have saved his life. And altered level of consciousness in a trauma patient, always think of hypoxia or decreased perfusion to the brain. Or it could be direct head injury before attributing it to the alcohol. So what is the optimal site and technique for needle decompression? Because a lot of times people try to do the needle decompression. The success rate is like 40%, 50%. That is what a lot of case series. So most important thing is how you do, where it's in the second intercostal space in the mid-clavicular line. So what you like about like 2 centimeters below the clavicle in the mid-clavicular line. Just, you know, in the males, the nipple is almost like in the mid-clavicular line. Just make sure that it is in the mid-clavicular line. Don't come medially. And you have to insert the needle perpendicular to the chest. That is very important, because if you put the needle, a lot of times the needle might go like this. It might be in the muscle. It will not go into the pleural cavity, so you cannot decompress it. Or if you go medially, you can injure the blood vessels. There have been reports of injury to the azygos vein, and on the left side there have been injury to the aorta, the pulmonary vessels to the heart, and all those things. So where you put the needle is very important. And what is the size of the needle for needle decompression? And so this is, usually we have like 18 gauge angiocath or even 14 gauge angiocath. Most of them are like 4 centimeters, like less than 2 inches, 1.5 inches to 2 inches. So so whether that is adequate, we don't know. So this is what they did is 774 trauma patients who underwent CT scan. They measured what is the chest wall thickness. So what they try to, what is the chest wall thickness more than 4.5 centimeters? They want to see how many people had more than 4.5 centimeters. So these are males left side, right side, female left side, right side. Less than 40, about 9.9% of the males had chest wall thickness more than 4.5 centimeters at the mid-clavicular line, just 2 centimeters below the clavicle. And in females, 35% had chest wall thickness more than 4.5 centimeters. More than 40, about 19% of males had chest wall thickness more than 4.5 centimeters. So the usual length of this angiocath may not be adequate to penetrate this. So needle thoracostomy clinical effectiveness is improved using a longer angiocath. So what they did is a level 1 trauma center. What they 2000 before 2011 they were using the 5 centimeter angiocath, and their success rate was only 41%. And this was like EMS before bringing the patient to the hospital and in the hospital also. And after 2011, they used the 8 centimeter angiocath, and it was 83% effective. So using especially if the patient is an obese patient, we have to use a longer angiocath for it to be effective. And I'm just concluding with a video of how to do this needle decompression correctly.
No audio, Einstein.
Are you able to hear?
Yeah, no audio yet. No audio yet.
I don't know.
That's okay. Please continue. We can see what he's doing.
So he is saying that what he is saying is
Einstein can explain. Einstein can explain.
Yeah, so what is happening is, he's saying that use a 10 gauge needle and 8 centimeter to 10 centimeter length needle. And he makes sure that this is the nipple and this is the clavicle just below the mid-clavicular line, just go perpendicularly. And because if you go medially, you can injure the blood vessel. And if you go a little bit lower down here, you can injure the heart on the left side. So, and so when you get a gush of air, you slide the needle. So thank you all for listening. Any questions?
பரோட்டா எனக்கு பிடிக்கவே பிடிக்காது. இந்த மலை
Can I make a comment, Einstein?
Yes, sir. Yes, sir.
Okay, I think spectacular speakers that Karupusamy run through how to run the ED department, and now you have shown us the practical issues, what's happening in the emergency department. With regard to tension pneumothorax, I like to share with a story that happened 10 years ago in British Airways flight. It was coming from New Delhi to London. And lady developed acute chest pain and breathing difficulties. And then the stewards called for medical help, and luckily there are 2 doctors who were returning from India after holiday. They were working in UK. And then they listened, they percussed and convinced it was a pneumothorax. And the history was that she had a trauma in Delhi and with the rib fractures. And they only had a green needle available in flight. So they put the green needle like you have shown, and the gas of air came out, and then she got better.
Good.
Obviously, they wanted to maintain her pneumothorax. 10 hours flight, not 10 hours, 7 hours flight to London. So they used a coat hanger. They straightened the coat hanger. I used it as a trocar. Any flight, they keep Foley catheter for guys going into acute urinary retention. So coat hanger, they threaded the Foley catheter, put in the chest after giving her some whiskey. And also the whiskey bottle was used as the underwater seal thing. And she survived. And the doctors wrote a case report in British Medical Journal. It's really improvising and medical care in the flight. Sometimes can happen in cruise on the sea. So these are the extraordinary things you may have to face if you are a frequent traveler. Thank you.
Thank you. Thank you.
Dr. Karupusamy and Dr. Arunachalam Einstein, they have given an excellent talk about the polytrauma as well as the emergency department in Coimbatore Medical College Hospital. Now I request Dr. Nambirajan, cardiology professor, to give a talk on myocardial infarction in young individuals. I request Dr. Geetha to take as a moderator.
Good evening to the people living in the evening time zone, and greetings to the global audience who are in their different time zones. Today, we, the faculty of Coimbatore Medical College, with the guidance of our dean and the constant endeavor of the global faculty, have made the first initiative of a global academic program. There is a beautiful phrase, think globally and act locally. Though there is a contention as to who has created this phrase, it is attributed to an environmentalist called David Brower. And he had given this as a slogan for Friends of the Earth. That's an environmental program which he founded in the year 1971. So this first initiative is and should always be a memorable initiative for integrating the local brilliance with the academic brilliance of the global faculty. And it should have a global reach. With this in mind, we believe that a wider perspective can be achieved in academics, work efficiency, ethics, and research. An enthusiastic, interactive participation from the postgraduate student community will definitely add value to every such presentation. So with this brief preliminary introduction, I am here to introduce the speaker of today, my colleague, Dr. Nambirajan. Dr. Nambirajan had his undergraduation at Madurai Medical College and post-graduation at Coimbatore Medical College. We were postgraduates between the year 1996 to 1999 in the Department of General Medicine. Following his completion of post-graduation in Coimbatore Medical College, Dr. Nambirajan worked at Stanley Medical College as a teaching faculty, and he was also in charge of the adult renal transplant program. He had a long stint as assistant professor in the intensive care department in Stanley Medical College. He completed his DM in cardiology in the year 2015, and he worked as an assistant professor in the Department of Cardiology since 2018 at Madras Medical College. Now he heads the Department of Coimbatore Medical College Cardiology Department, and he's very active with many of the postgraduate teaching programs, and he has, to his credit, more than 20 national and international papers. And he has contributed to the anticoagulation position statement for treatment of COVID patients in India, and it is something to be applauded. He has recently been a guest speaker in an international program relating to young myocardial infarction, and this bears relevance for today's program. So with this brief introduction of Dr. Nambirajan, who is here to speak about young myocardial infarction. So this topic actually does not evoke something that, it is something that evokes a pathos, I would say, because young myocardial infarction is now becoming an epidemic in the Indian population. And though we see in the government setup many patients from the lower socioeconomic background, it seems to spare none, irrespective of caste, color, creed, gender, socioeconomic status. People come from all across, in all hues. And we find that they can be atheromatous, non-atheromatous, substance abuse, hypercoagulable states. And so to highlight on young myocardial infarction, we now have Dr. Nambirajan with us. Thank you.
Yeah, very good evening, one and all. Thanks for the introduction, Geetha madam. Am I audible, sir?
Yes.
Sir, am I audible?
Yes, yes, you're audible.
Thank you. Thank you. Very respected Dean madam, respected HODs, respected senior faculties, alumni, senior members, and first of all, I'd like to thank for this opportunity. My topic would be of young myocardial infarction experience from our center. As you all know, coronary artery disease has emerged as a major health problem in India. It has become an epidemic proportion. and the incidence has increased rapidly. As ma'am was telling, it has increased very rapidly. You could see the around 13% in urban population and around 7% in rural population. And it's although uncommon because of the epidemic transition, it's emerging. The CAD in young is an emerging trend in India, and the CAD is more than life and death. It's not only a simple myocardial infarction. It has a huge impact on the patient psychology, patient himself, and impact on the family, socio-economic burden, and the daily disability adjusted life years, the ability to work further, and the long-term morbidity. So simple MI, as ma'am said, it's not a simple heart attack. It affects the whole individual and the family and the society. So the premature CAD, it has got a lot of definitions, a lot of adjustments in the age. So when we see the incidence of the coronary artery disease from the previous studies, the young MI in overall, it is less than 55 years in men, and it's less than 50 years in women. As we see, the CAD in young Indians, it's more high than compared to the Western part. It occurs a decade earlier than the Western counterpart. In Western counterpart, actually, there is a trend decreasing in trend, but the risk factors for the coronary artery disease is increasing. When you see the presentation of young MI, it's almost 2/3 present as the non-ST elevation MI and 1/3 present as the ST elevation MI. Mostly they don't have the prodromal syndromes, and the extent of disease is usually less extensive compared to the elderly population, usually a single vessel disease. The spontaneous coronary artery dissection, which is seen commonly in women in pregnancy, is a rare disease. It's seen only in women. And people have a tendency, I'm young, why should I worry about heart disease? But it's not the same. We see a lot of young patients, the first event being the last event for them. So this is a warning for the youngsters who are listening, to educate the public or the common public and make the society a well prevented society from your coronary artery disease. These are all the commonest risk factors, conventional risk factors, as you have been aware, especially the diabetic, India being the diabetic capital of the world, diabetes, hypertension, and apart from that, your lack of exercise. Now it is called as the recent smoking. Sitting together in your chair for more than hours together is the recent smoking, and the lack of fruits and vegetables and psychosocial and other risk factors. Of course, the dyslipidemia and smoking is there. These are the common, some of the common pathophysiology which we are facing in the young CAD. 80% accounted by the conventional. Am I audible?
Sir, you are audible, but your PPT is not moving, sir.
PPT is not moving. Okay, let me check. I don't know. I am able to. The screen is being seen over the, my screen.
Yes, sir, it's seen, but put it on a slideshow mode, sir.
Slideshow mode. Yeah. Now you are seeing? Now you are seeing? Ma'am, someone please.
We are able to see Dr. Nambirajan, but I think as stated, please put it on the slideshow mode.
Yeah, slideshow mode. Okay, I'm moving. Now it is moving. Now it is moving. Okay.
Seen, audible.
Thank you so much. 80% accounted by the conventional coronary atherosclerotic disease, 4% due to congenital coronary anomaly, 5% due to embolic phenomenon, 5% associated with coagulability, and 6% due to coronary spasm, inflammatory disease, radiation, trauma, and substance abuse. This substance abuse is also seen in Western, is also now seen in more number of people in our place also. These are some of the mechanisms. As I said, this is the coronary spasm. This can occur in any patient, especially in women or men. And this is the commonest ruptured atheromatous plaque rupture, and this is coronary arteritis and some of the mechanisms. So this data from India, the global burden of disease study, which has been done in 2016, says the prevalence of CAD is rapidly increasing. CAD is the leading cause of death. Around 25% of the whole death is accounted by coronary artery disease. And more than
excuse me.
Yeah.
Your slide has not moved. The same slide we are visualizing.
Okay.
Yes.
Now can you see, ma'am?
Yes, the data from India.
Yeah.
Can we make it a slideshow, please? So it will be more helpful.
Yeah.
Full screen slideshow means then we will see the slide.
Slideshow mode only.
Yes, sir.
Yes, it is in slideshow only.
Yeah. More than 1/3 of the STEMI occurs in population below 40 years. This is actually a worrisome number. You can imagine the seriousness of the disease, how it is growing. The STEMI in Tamil Nadu, with our statistics, the annual mortality is very much high, 70–80%, and you can see the annual incidence. The urban, as I already said, it is around 13, and rural it is around 7. And this is the picture around India. You see the red area around our southern states. We have got a higher incidence of coronary artery disease, and as a whole, India has got the leading coronary artery disease predisposition. Actually, we have a premature atherosclerotic tendency due to our atherogenic burden because of the diabetes and increased triglycerides. These are all conventional risk factors, as I said. Apart from your conventional risk factors, we have this non-conventional risk factors, especially homocysteine and plasminogen activator inhibitor. We don't do often in normally these sort of non-conventional in any of the patients. But in our actually, we are doing a study which I will be coming in the forthcoming slides. In those patients who do not have the conventional risk factors of hypertension, diabetes, dyslipidemia, smoking, alcohol, and IBMI, we have done this homocysteine in certain number of patients, and we have done other stress, anxiety, depression scores also we have included. This is the study which I was saying. This study we started last year, and more than 320 patients have been included in this study. And we have analyzed the conventional and the non-conventional. We have included a anxiety depression score, hospital anxiety depression score, and this study is ongoing. We have included only less than 40 years of age. More than 300 patients have been collected, and these are all the age-wise and sex-wise distribution of cases. As you could see, the age group 18 to 30 years, we have quite chunk of people, and 31 to 40 is the major.
Yeah. Is it just us, or is the screen frozen at data from India?
Yeah, this is our data from Coimbatore Medical College.
The slideshow has been frozen on the page at data from India.
No. This is our study.
Just now only you have changed the slide.
Okay, now, maybe I'll just stick on to the. I will not go for the full screen. I'll just stick on to the off screen. So this is the clip classification of our study, and this risk factor analysis. As you can see, this is the smoking was the highest among the males. Next to that, alcohol and dyslipidemia. Of course, your depression, you can see 35%. This was a new insight from our study. Since the young MI have a genetic predisposition, family history was present in 12%. So apart from the conventional risk factors of diabetes, hypertension, and dyslipidemia, you can see the smoking tops. Next is alcohol, and the new insight is anxiety and depression scores more in our study. So this is angiography results. STEMI actually dominated the picture. So next, single vessel disease was the commonest one. Associated findings like diabetes, smoking, as I already said. So this is the conclusion from our study. So the maximum cases were 30 to 40 years. You can just imagine around 300 people were screened and angiography done, 30 to 40 years, 88%. And the mean patient age was 35 and 87% for male. STEMI was the huge presentation, 84%, and cardiogenic shock was 5.2%. So, yeah. There were no obstruction, myocardial infarction with no obstruction, coronary arteries was seen in 4% of cases. Most commonest conventional risk factor, as I said, it was smoking, alcohol, and diabetes. Most common non-conventional risk factor was psychiatric causes like anxiety and depression. This has to be taken note. In future, we need to assess this in the population or in the society as a whole. Higher homocysteine, we did it for a couple of patients in which we couldn't find the conventional risk factors, and 10.7% of our patients, especially males, having higher homocysteine level and higher lipoprotein A. This is an individual risk factor among the Asian Indians, especially Indian counterpart. This cannot be treated as a whole with any of our statin or any anti-lipid treatment. And we did this for a couple of patients, and there were 8%. And as we all know, atherosclerosis starts from your birth. It starts from 2 years of age, and from the third decade, it grows up due to subsequent comorbidities and other risk factors. It goes into a plaque rupture or a erosion. So the prevalence and mortality is on the increasing trend right from 1990 to, if you from this study, you can very well understand the increase in trend in CAD. This create registry. Sir?
Nambi, burota சாப்பிட்டா இந்த மாதிரி பிரச்சனை வருமா?
Sir, varum sir. Kandipa. Varum sir. This Indian create registry also, it has told, and it has revealed that actually in our country, in our place, we have a tendency for thrombolysis rather than primary PCI. But our government, Tamil Nadu government, has brought a policy last year, and we are focusing. We have achieved 100% thrombolysis in our country, and we are focusing on much more better than that. We are doing round-the-clock primary PCI in our Coimbatore Medical College, and we are focusing 100% pharmacoinvasive this year. Our government has given us the guideline and supportive things for. These are all some of the non-atherosclerotic causes of MI. Embolization into the coronary artery from infected endocarditis, prosthetic wall neoplasm, and other hypercoagulable states. Spontaneous coronary artery dissection, as I said, it is more common in women, especially your pregnant women. Syphilitic aortitis, vasculitis, Kawasaki, and with your MIS-C, lot of vasculitis, coronary vasculitis with this corona also we are seeing a lot of cases in pediatrics. Our pediatric professors have highlighted that. Mediastinal irradiation for cancer chemotherapy, and homocysteine, as I said, and cocaine, which is not so common in our place. So to conclude, Indians, we have a higher risk of coronary artery disease. Apart from conventional risk factors, we need to focus on non-conventional. So the younger individual, we need to focus on the family history, and we see a lot of gaps in the present setup of primary and secondary prevention. We are seeing a lot of gaps. Actually, I am not convinced with the our primary prevention before the disease and after the disease. So we need to change the strategy from routine risk score evaluation into using the imaging techniques, especially the coronary calcium CT coronary guided imaging is much more useful in identifying the vulnerable plaque prior to the plaque progression. So we need to include this coronary CT in screening for the young people above 30 years with risk factors, and because risk factor stratification is not completely, it cannot find out the risk people. So we need to change the risk stratification, and we need to find out give importance for coronary calcium score screening. And this is an example from our, actually this is a case, 26-year-old male, chronic smoker, slightly obese. I'm just showing a couple of the cases which we have done in our place. So this patient, he had a osteoproximal left anterior descending artery. You can see completely occluded from the ostium, and we stented this patient and he became all right. So these are all the some of the highlights of our interventional procedure. You can see the total cutoff of the right coronary artery and causing an inferior wall MI, which was revascularized a couple of days back. So we take up these cases in an emergency manner, and we do a coronary angiogram. And this is, you see the tight lesion, 90% lesion of the LAD, and it was stented and the flow established so that it can be prevented from further complications of heart failure. So this is another L6 lesion, LAD lesion, actually osteoproximal LAD and a L6 lesion, which was revascularized, and this patient is doing well now. So apart from the coronary revascularization, we are doing permanent pacemakers, and just to highlight what we are doing in our college, because the youngsters should understand what is going on in our department. Actually, the department was started in 1975 with one assistant professor and professor with a small ICU. Now it has grown to a bigger level with the professor and associate professor, 5 assistant professors and 8 postgraduates, 4 postgraduates per year. We are in the process, and we have got 8 postgraduates. And our cath lab was started in March 2018, and we have completed more than 5,000 procedures as of now. We have, ours is the main center, hub center. We have more than 13 spoke centers. We are getting from adjacent nearby 5 districts every now and then. Throughout the day, we are getting referral cases. And as I said, the permanent pacemaker insertion was started in September 2019, and we have done more than 20 pacemakers, permanent pacemakers. And we started in February 2021 for the mitral stenosis percutaneous transfemoral PTMC program, and it is going on. And we are routinely performing complex coronary interventions and left main interventions. We had a OCT IVS program, and we did, this is our statistics. It speaks. We have been blessed with the better environment by our dean's guidance, and we have got a wonderful professor and a wonderful assistant professor team with a beautiful postgraduates. So we were able to achieve, despite Corona crisis, we have done in 2018, the number speaks about everything. Total 5,507 procedures till date. This was achieved in a 4-year period. Compared to other leading hospitals and government hospitals in Tamil Nadu, they were able to achieve after 10 years only. So the concluding message is coronary artery disease is in an epidemic proportion in our country, especially in our Tamil Nadu. It occurs 1 year earlier than the counterpart, and the disease severity is very severe, and diffuse lesions are seen in coronary angiogram. Mostly the young MI, they have high risk factors which can be modifiable. So I request all of your people, the medical fraternity, to consider this and educate the common people to take care of the conventional and non-conventional risk factors, so that this menace of acute myocardial infarction and the mortality and the morbidity associated with this will end. Thank you very much for your patient listening.
Thank you very much, Dr. Nambirajan. That was definitely educative. It's not only that we carry the message to the population, I think we should take the message for ourselves because of the nature of our work, the nature of our lifestyles, and of course, it is multifactorial as you stated. And I would also like to add one more point here. Substance abuse is something which you have mentioned, and I think that is one area which is a gray area where you may never get the history. And I think that is also quite contributory, given that you have a younger population coming with coronary artery disease. If I may be permitted to just take a minute To give an example, I remember a patient around 2 years back who was brought to the ICU, just 24 years old. He was found locked in his room and unconscious. And we were clueless as to the cause. One thing we found was he had a very high blood pressure and he had very high blood sugars as well. There was no preceding similar history in the past. And with a lot of difficulty, we got the patient shifted for the CT scan brain. Meantime, on clinical examination, I found that there were 7 linear prick marks over the left radial region. And this was the clue. And then when we got the CT scan of the brain done, we had massive intracerebral hemorrhage with intraventricular extension. And later on, retrospectively, hesitatingly, the family accepted that he was a cocaine user. So I think this point can also be taken into consideration. Thank you very much for your talk. Questions are invited. If there are questions, please go ahead.
Thank you, ma'am.
Okay.
So,
Sorry. It's a nice talk, Dr. Professor Nambirajan. You said 87% are males, ages between 30 and 40. It's really depressing and shocking. I think it's a lifestyle of young males in India is deteriorating with alcohol, smoking, drug abuse, as mentioned, and all the expensive cars. They don't do any exercise. It's worrying. And as Dr. Geetha said, public education is probably essential.
So, Dr. I'm very happy to see Dr. Nambirajan. He is my schoolmate.
Yeah.
From 6th standard to 10th standard.
Yes.
In Lithio Higher Secondary School, we were classmates.
Yes.
Very happy to see you.
Yeah, happy.
Prof.
Thank you.
Yeah, and young males routinely we do, like if somebody with the MI comes at 30 or any endocrine, we routinely do drug screen for cocaine, and that's routine here.
We don't have a screening, ma'am. We don't have a proper screening for any of the drugs, commonly used drugs. That is the thing. Actually, Coimbatore, we are getting a lot of cases, sir. Lot of cases. Yeah. If you just visit our if you visit our ward, there are no places. Every day, all the beds are full. Some amount of some other risk factors like your air pollution and other factors are also there. Stress plays a main important role. Yeah, because we have quite chunk of young MI patients who do not have conventional risk factors. They're teetotalers. So the stress, anxiety plays a main important role in young MI. Yeah. The students also should take care of their health. They should go for meditation. They should not be too anxious. Too much of peer pressures with our gadgets, madam. WhatsApp, everything. Too much of we are pressurized to perform, the students. So they should also take care as a whole. They should take care of their health, proper diet and exercise.
They have a lot of academic pressure starting from kindergarten. Yes. So it starts very young. So there's no doubt about it. And one more point I would like to mention here is the quality of air. We are surrounded by very heavy air pollution, and air pollution is a well-known contributor. So it's very difficult to quantify exactly. So it is multifactorial.
Yes. Yes.
Thank you, Nambirajan.
Thank you, ma'am. Thank you.
And now I request Dr. Sivakumar sir to be the moderator for the next topic, which will be given by Dr. Arunachalam Einstein on cardiac arrest.
Madam, good evening. Is it audible?
Yes. Yes.
Because of some emergency, I am not able to participate in the initial meeting. I am Dr. Sivakumar, Professor of Medicine, Coimbatore Medical College. I did my MBBS in Madurai and PG in Stanley Medical College. So Coimbatore is my native place. So I am here for the past 25 years in Coimbatore Medical College. I like to few words about cardiac arrest. It is really a catastrophe for the doctor as well as for the patient. If the patient survives, okay, but if the patient doesn't survive, the convincing the patient, attenders, relatives, especially, it's so horrible. I have two experience during my period in 1991, early 1991, when I was duty medical officer in one of the clinic. An alcoholic came to the hospital with a severe abdominal pain. Then I gave dicyclomine and the ranitidine. During the IV ranitidine infusion, the direct IV, the patient suddenly collapsed. Then I did a cardiac massage, just a cardiac thumb. Then, fortunately, within few minutes, the cardiac rhythm has been restored, and he was shifted to the ICU, and he survived. Then, after working as a consultant in a private hospital, a couple of 1 decade before, a patient received in an unconscious state with no history. Suddenly, the patient had a chest pain around 70 years. He's 70 years old, diabetic and hypertensive. I received the telephone call from a duty medical officer at it. Then I asked to give a DC shock first. Don't worry about all those things. Fortunately, he survived and he lived. He had an anti-receptor MI and he was thrombolized, though the age is against. At that point of time, we thrombolized the patient. He survived for next 2 years and died due to ischemic cardiomyopathy. So these two things I always say. An early and effective intervention, if the patient responds to your treatment, cardiac arrest may be maybe the patient may get benefit, but we don't know how, which patient will benefit. That's the crux of the situation. So with this with this introduction, I'd like to call upon the Einstein sir to deliver his lecture. Thank you.
Thank you. Thank you again. And I'm trying to share my screen. Are you able to see the screen?
Yes, sir. Yes.
Okay. Thank you. So I will start with another case. This was a case which I saw. The patient was working in Boeing plant. Boeing, the aeroplane assembly factory is near my hospital. So he's a 42-year-old male, collapsed while he was at work. One of his co-workers immediately checked for his pulse and found him unresponsive without a palpable pulse. He called for help and immediately started CPR. So the other co-worker called 911 and activated the EMS. Another co-worker brought an AED and attached it to the patient. And the AED said shock advised, and the patient was shocked, and he regained consciousness before even the ambulance arrived. The EMS, the emergency medical service, the ambulance brought the patient to the emergency department, and I evaluated the patient. And this was his EKG. The EKG here shows ST segment elevation V1, V2, V3, V4, V5. And reciprocal ST segment depression in lead 2, 3 AVF. So he has a massive anteroseptal myocardial infarction. And, he was given aspirin and Plavix was loaded, and the patient was taken to the cardiac cath lab, and he had a total LAD occlusion. You see this proximal LAD, total occlusion. And this is the left circumflex artery. And so then after angioplasty, his LAD, TIMI3 blood flow was restored. And so the patient was discharged home 3 days later, and the echocardiogram revealed his ejection fraction was 60% at the time of discharge. So, most of the time, initially, it is first few minutes of the MI, it is the electricity, so it goes into VFib. So if we do defibrillation quickly, there's not much damage to the muscle, and patient goes up with a good ejection fraction. because but if the patient is having coronary occlusion for a long time, then they go into cardiogenic shock and all problems. So Seattle, this is happens frequently in Seattle. Most of the patients walk home with the normal ejection fraction, come cardiac arrest and go back. And this is a cardiologist at the University of Washington. So what he did in 1969, he said world's first mass training in CPR. So he was responsible for training about 1 lakh people in Seattle, so that people can immediately start CPR when the patient gets cardiac arrest. And this is Dr. Mickey Eisenberg. He's a professor of emergency medicine at University of Washington. And in 1981, what he did was, even if the lay people are given instructions and they get training, they forget. When somebody suddenly collapses, they call 911, they don't know what to do. And so whenever somebody calls 911, the EMS dispatcher gives them instruction how to give the CPR, like how many compressions, how much depth, and all those things. So when they give the instruction, bystander is more likely to give CPR without an instruction. Without an instruction, people will be just watching. So this is case. Is there audio?
No audio, Einstein. You can explain to us.
Is the audio? Are you able to hear the audio? No? So the AED is telling to cut the clothing and to apply the AED. So and the AED is giving instructions how to place the pad. So AED is analyzing. And so they So, so that patient survived. So the cardiac response to counter shock is largely time dependent. So if a counter shock can be performed within 3 minutes of the onset of ventricular fibrillation, 70 to 80% of the patient will convert it to rhythm associated with adequate perfusion. Like about 2-3 years ago, I was seeing a patient in the emergency department, and the patient came with chest pain, and he was diaphoretic, and the initial EKG didn't show any ST segment elevation, and but the patient was diaphoretic, and so I asked the nurse to put the defibrillator pads on the patient, and then I was talking, and he was explaining how his chest pain started, and it is radiating to the back, and he was having nausea, and he was telling the history, and suddenly his eyes rolled up, and he became unconscious, and the monitor showed VFib. And so I immediately called the code blue button, touched the code blue button, and I defibrillated the patient, and the patient woke up, and he continued the history as if nothing happened. So, if you can counter shock immediately, then, there is a very high survival rate. So for every minute that passes without CPR and defibrillation, the chance of survival decreases by 7 to 10%. So this is, done by professors at University of Washington, and this is quoted all the time in all the resuscitation journals. This data is quoted for every minute that passes without CPR and defibrillation, the chance of survival decreases by 7 to 10%. And if immediate CPR is provided until defibrillation, the probability of survival only declines by 3 to 4% per minute. So the question is mouth-to-mouth breathing, rescue breathing necessary? There is a question because a lot of lay people are not, are hesitant to do this, and so they don't do CPR at all. So what they did is they did some animal studies in pigs, and what they found was whenever they attempt stop the compression for giving the rescue breathing, the hemodynamics goes down, like the coronary perfusion pressure and the aortic pressure and the cerebral perfusion pressure, everything decreases. Because we all know that this oxygen delivery is a product of cardiac output multiplied by the oxygen content of the blood. So even if you give rescue breathing, if the oxygen content increases, but the cardiac output decreases because you are not doing chest compression during the time. So what they found was the oxygen delivery was not different, whether you give rescue breathing or not. So this was done in the pigs. So what about humans? So this is a trial again done in Seattle. Cardiopulmonary resuscitation by chest compression alone or with mouth-to-mouth ventilation. So what was the result? What they found was chest compression plus mouth-to-mouth ventilation, discharged alive from the hospital was 10.4%. Chest compression alone, discharged alive was 14.6%. So chest compression alone had a better outcome than chest compression with mouth-to-mouth ventilation. So the survival to hospital discharge was better among patients with chest compression alone than assigned to chest compression plus mouth-to-mouth ventilation. But the difference was not statistically significant. So this is the conclusion. So CPR with chest compression alone is similar to CPR with mouth-to-mouth ventilation. So this is this study. This is another study in 2010. CPR with chest compression alone with rescue breathing. Again, same results. the survival to hospital discharge was 12.5% with chest compression alone, and it was 11% with chest compression plus rescue breathing. So same way, so they say strategy for CPR performed by layperson that emphasizes chest compression alone and minimizes the role of rescue breathing. So this is another study, again, chest compression alone CPR with standard CPR, which includes the mouth-to-mouth breathing. So chest compression alone 620, the 30-day survival was 8.7%. Standard CPR with rescue breathing, the 30-day survival is 7%. So chest compression alone CPR is the best solution for the lay people. So does teaching CPR to the lay public improve survival? So this is in Sweden, has 3 million people were trained in CPR. So the question was, does this training increase the frequency of bystander CPR, and does this training increase the survival rate of out-of-hospital cardiac arrest? So this was in 1990, about 7.5 lakhs people were trained, and only 35% performed CPR before the arrival of the EMS ambulance. But now about 27.5 lakh people are trained, and about 68% are above 65% are receive CPR before the arrival of the ambulance. And the 30-day survival rate also was more than twice when CPR was performed before EMS arrival. So the layperson providing CPR is associated with better survival. So does teaching AED usage to lay people improve survival from cardiac arrest? So this is in Las Vegas, Nevada. We have a lot of casinos there. So before 2000, only medical personnel were using defibrillators. So only nurses, doctors, and emergency medics, paramedics were using this defibrillator. So in 2000, what they tried to find out is whether we can train the lay people to use defibrillator, and what is. So outcomes of rapid defibrillation by security officers. So what they did is, this casino security officers, they trained in using the defibrillators. So what is happening? What is the result? So AED was used in 105 patients whose initial rhythm was ventricular fibrillation. 53% survived to discharge from the hospital. That's a remarkable percentage. And the survival rate was 74% for those who received their first defibrillation within 3 minutes after witnessed collapse. So, if the public used the defibrillator quickly, the survival rate was very high. So it was published in New England Journal of Medicine. And then this is in 2004. Again, multiple cities in the USA, whether public access defibrillation and survival of out-of-hospital cardiac arrest. So this is the result. CPR only, 107 patients. Survival to hospital discharge was 15. CPR plus AED, and then the survival to hospital discharge was 30. So training and equipping volunteers to attempt early defibrillation increases the number of survivors to hospital discharge after out-of-hospital cardiac arrest. And trained laypersons can use AED safely and effectively. So this is another in Japan, public access defibrillation for out-of-hospital cardiac arrest. Outcome, again, same thing. So about 4,500 people got defibrillated by the public. Survival rate at 1 month was 44.7%. If the public defibrillator was not available, and then the survival rate was only 27.9. And good neurological outcome also was 38.5 when the public had defibrillated the patient before the EMS arrival, and it was only 18.2 if they had to wait till the ambulance arrives to defibrillate the patient. So the increased use of public access defibrillators by bystanders was associated with the increased number of survivors. So same way, another study, before arrival of ambulance, like AED is automatic external defibrillator, is AED. Applied before EMS, the survival rate is 35%. Bystander CPR, but no AED was applied before ambulance arrival, the survival is 20%. So, you know, the application of AED in communities is associated with nearly doubling the survival after out of hospital cardiac arrest. So these results reinforce the importance of strategically expanding community-based AED programs. And this is a meta-analysis of multiple studies in multiple countries. All patients with cardiac arrest, the survival rate is 7.1%. When the emergency first responder provide defibrillation, the survival rate is 28.6. When lay bystanders provide defibrillation using AED, the survival rate is 53%. So this is in Seattle. In 2002, the out-of-hospital cardiac arrest survival for witnessed ventricular fibrillation arrest was 26%, and slowly now it is around 62%. 62% are discharged from the hospital with good neurological outcome. Almost if it is a witnessed ventricular fibrillation cardiac arrest. So how is it possible in Seattle? So what they are doing is adoption of high quality CPR method by the emergency medicine technicians, adoption of telecommunicator CPR, whereby the 911 emergency personnel provide instant CPR instructions by phone. Because a lot of people might be hesitant, they might have learned CPR, but they don't know how to do it, and they might have forgotten. So the 911 emergency personnel will guide them over the phone how to do it. And there is increased public availability of AEDs. So all the police cars have AEDs, and it is all present in all the malls, and I mean all the places, public places have AEDs. And high rates of CPR training for local residents. Almost more than 90% of the local residents are trained in CPR. So what is high quality CPR? You know, CPR has to be done properly, otherwise not much use. High quality CPR is very important. Just compressing the chest is, half-heartedly is not going to help. So a depth should be at least 5 to 6 centimeters for an adult and child. It has to be at least 5 to 6 centimeters. Between 5 to 6 centimeters, at least 5 centimeters. And a depth of 1/3 the AP diameter in an infant. That is corresponds to about 4 centimeters. And the compression rate of 100 to 120 per minute. That's very important. And allow full chest recoil before the next compression. That is also very important. And minimizing interruptions in chest compression. So you can't just compress and then leave. Then what happens? The cardiac output suddenly decreases, and cerebral perfusion and everything goes down when you stop the chest compression. And so the minimizing the interruption should be less than 10 seconds to check the pulse and other things. And also avoid excessive ventilation. Excessive bagging increases the intrathoracic pressure and decreases the venous return, and also decreases the survival. So what is the post cardiac arrest care in the hospital? If there is return of spontaneous circulation, then what you do is most of the people who had prolonged CPR, their mental status is down. They don't, you need to intubate those patients. and maintain an oxygen saturation between 92 to 98%, because if you do more than 100% hyperoxia, free radicals and less survival. So, and the PaCO2 should be maintained between 35 to 45 millimeters, and maintain systolic blood pressure more than 90 millimeters. You know, you can give IV fluids, and vasopressors are needed. 12-lead EKG, if it shows a STEMI, is taken to cardiac cath lab. And if they are comatose, obtain a CT scan of the head, EEG for seizures, non-convulsive seizures, obtain and maintain the blood glucose, and avoid barotrauma. And if they are not comatose, monitor and the targeted temperature management for a comatose patient. You know, initially it was 33 degrees centigrade. Then they said 36. Now they say between 36 and 37. And most important thing is to avoid fever. Fever will decrease the neurological outcome of cardiac arrest victims, and monitor them. So here in the United States, multiple airports, what they are doing is they are having this kiosks where what they do is people can go and do chest compression and see, it will give you a score, how good you are doing the chest compression, whether you are depressing 5 minutes, whether 5 centimeters, whether you are depressing the chest by 5 centimeters, and whether your heart rate is between 100, whether you are giving at a rate of 100 to 120. And so it gives you a score. And which compressions you are allowing full recoil and all those things. So it's very fun, and a lot of kids do this in the airport. And so this is a summary. You know, in hospital cardiac arrest, you have to do early recognition. Like we have like rapid response nurse. So whenever somebody who was admitted to the hospital in the floor, if their oxygen saturation goes down, or when their heart rate goes up, or things like that, or when the patient is bradycardic, they immediately go and assess and call the doctor, and make sure that the patient they transfer them to ICU, and make sure that they don't go into cardiac arrest. And if they go into cardiac arrest, then code blue, and then high quality CPR and defibrillation and post cardiac arrest care and recovery. And a lot of people also have like post-traumatic stress and anxiety and other problems. So you need, and this is out of hospital cardiac arrest. You have to activate the EMS, start high quality CPR, defibrillation, then advanced resuscitation, post cardiac care and recovery. So in summary, what I am saying is everyone should be trained in high quality CPR for really trying to make a difference, because 80% of the cardiac arrest happens at home. And as Professor and Dr. Nambirajan said, a lot of young people, 30 to 40, are getting heart attacks, and you know, and a lot of productive life is lost. Or even if you you know, so for survival of those patients, every family member should be knowing CPR, and a lot of volunteers have to be trained to use AEDs. And so we have to know where the AEDs are available, and all those things will improve the survival from the cardiac arrest. Thank you very much. Any questions?
Dr. Geetha, am I allowed to comment? Or Dr. Lakshmi Narayani?
Go ahead, sir.
Thank you for your good elaboration about the cardiac arrest and the first aid, which has to be taken outside the hospital as well as inside the hospital. And now I ask Dr. Sivakumar sir to tell some words.
Thank you, Einstein sir, for your elaborative lecture on cardiac arrest. Around 25 lakhs of people die per year in India due to cardiac arrest. This is a rough estimate. So see the burden on the family as well as to the society. And we have initiated certain interventions like implantation, putting up automated external defibrillators in public places like railway stations and some of the metro stations and bus stands also. But bus stands in Tamil Nadu has not taken up, but in railway stations it is being given. And our 108 service gives a, it is all the technicians are well trained with the BLS, basic life supports, with the cardiac compressions. And we are planning for the telephonic CPR instruction through 108 also being given. So still it is a long way to sensitize the society as well as apply it in a correct way and right time. So I think with this conclusion, we will close the session of cardiac arrest. Thank you. Thank you for the nice listening. Any questions from the audience? I think there are 21 chats are remaining, so the speakers can answer for this.
Shankraj wanted to make a comment, sir. Please go ahead.
Okay. Thank you, Dr. Geetha. Just on behalf of the alumni, I like to congratulate all the faculties involved today, the organizers, including Dr. Nirmala, and all the speakers for giving a valid information. I just want to make one comment about CPR. In the United Kingdom, we are expected to do annual CPR, and we are given certificates in order to support our appraisals. That's how we maintain our registration in General Medical Council. I think similar thing prevails in the rest of Europe and US. I don't know what the status in India. The faculties, are they taking CPR annually, postgraduates? I don't know the system in India. It's nice to hear from you what's happening in Coimbatore Medical College Hospital.
Sir, in our hospital, even for the first year itself, nowadays, it's a collaboration with the clinical sites. We are giving training for the student, first year MBBS itself, from the anesthesia department and from general surgery department for the trauma, what are the initiative and how we have to receive the patient and give CPR. And during their CRRI. So in the internship also, in the anesthesia department, when they are posted there, and one day they are giving a training program. And when they are in IMCU and other medicine emergency departments also, they are giving the CPR procedure for all the patients in needed places. So already they are trained. When they completed their CRRI, they should have know all these things. So our CRRIs are well enough to get trained in the CPR procedures.
Are they able to execute
Now
it? If somebody...
Yes, sir, even if yes. Dr. Geetha, you can answer.
So coming to your question, ma'am, Dr. Lakshmi Narayani has stated that we are undertaking such training programs, but there is no mandatory certification at the end. I think that will definitely make a difference, as you have stated, but we don't have any such mandatory programs as of now.
Can I say a word? Hi, everybody. I'm Sajni Thomas, 1971 batch. Thank you all. This has been amazing. It has been a real eye-opener and bringing awareness, not only to the doctors, but also to any of the family who are watching this session with the doctors at home. But no, just being aware of high quality CPR is so important. And I know Dr. Kalyan Sundaram and Dr. Karupusamy, they are working on this to try and initiate sort of like an Indian training center certification, which is what is happening in India. It's because the American Heart Association training is much more expensive. So once that is facilitated and that comes in like the NRP and the PALs, I'm sure there will be more awareness. Little steps, small steps, but I think Coimbatore Medical College is in the right direction, and you are blessed with such amazing faculty and dean to support. So heads of department, go forward. You have all the support from everybody. Thank you all. This was wonderful. Thank you. And please make use of the sim lab. We are slowly getting it all equipped with for basic CPR, for high quality chest compressions, for the use of AED, and now to identify the rhythms. You are going to get the rhythm simulator too. So please, heads of department, take your students or take your CRRIs in small groups and have this training done to them. Thank you.
Thank you very much, ma'am.
Now I request Dr. Sivakumar, Associate Professor of General Medicine, Coimbatore Medical College, to give vote of thanks.
Thank you, madam. It is a great honor for me to offer a vote of thanks on this occasion. First of all, I would like to thank our beloved and respected Dean Madam for inaugurating this webinar. She is the driving force of this institution, which is scaling new heights day by day. And the latest altitude is our emergency department, which is one of the best in the state. I take great pleasure in thanking the Global Academic Alumni Committee for making this webinar happen. This platform has proved to be a great resource of knowledge, and it is a window for the world for our students. That's the feedback I received from them. I thank the speakers, Dr. Einstein, Dr. Nambirajan, and Dr. Karupusamy for enlightening us with deep insights and interesting facts on most relevant topics in emergency medicine. I would also extend my heavy thanks to the moderators, Dr. Lakshmi, Narayani, Dr. Sivakumar, Dr. Geetha, and the co-chairperson, Dr. Shanmugaraj, for their words of wisdom, which was a valuable input to the session. Last but not the least, I thank all the participants who logged in from various parts of the world. The sun never sets for the CMC alumni empire. Thank you all for making this session a great success. Thank you.
Yeah. Thank you.
Thank you one and all for participating in this program. Thank you all.
Thank you.
Conclude this session.
Hello, everybody. Thank you for organizing this nice program. Co-chair along with Dr. Balavankat. It was very nice, Dr. Lakshmi. Well, and it's a good start. Let us continue the same tempo. Thank you and all.
Thank you.
Thank you.